Hi, very good morning. I'm Dr. Janak Patel, MD, General Physician. Today we'll be talking on one of the very odd topic, that is fat embolism and fat embolism syndrome. No doubt it is not a very common condition, but orthopedic surgeon, general surgeon will come across such condition quite often. If you are aware of such condition, and if you pick up those cases, you can reduce the mortality, because mortality rate is very high in fat embolism syndrome. So when a fat produces an embolism, fatty material, it will give rise to fat embolism, and if there are symptom signs grouped together, we call that as a fat embolism syndrome. So we'll be talking under those common headings like definition. So by definition, fat embolism syndrome is a clinical diagnosis. There is no laboratory test. Mostly it is associated with a long bone and pelvic bone fractures, and more common with closed fractures rather than open fractures. Single long bone fractures can have 1 to 5% chance of fat embolism syndrome, and it increases with number of fractures. It starts within 24 to 72 hours from the initial insult, and mortality rate is as high as 5 to 15%. It is quite high. And three classical TRIAD symptoms which will tell you that this is fat embolism syndrome is pulmonary dysfunction, neurological symptoms and signs, and petechial rest. These are the three classical triad which are seen. After ruling out other condition, the diagnosis of fat embolism is usually put. So diagnosis of fat embolism syndrome is mainly by exclusion of other criteria. It is very common with fractures of long bones. It will consist of hypoxia, respiratory insufficiency, neurological impairment, plus petechial rest. And it occurs within 24 to 72 hours, mainly because of the long bone fractures or pelvic bone fractures. And there is no other etiology like pulmonary embolism or ARDS. Put together, we say that if a person with a long bone fractures or pelvic bone fractures within 24 to 72 hours presents with pulmonary dysfunction, neurological abnormality, petechial rest, ruling out the other etiology like pulmonary embolism or ARDS, always suspect fat embolism syndrome, or short form called FES. Fat embolism means fat particle or droplets that travels through the circulation. And embolism is a process by which the fat emboli passes through into the bloodstream and lodges into the blood vessels. While syndrome is a clinical manifestation of fat embolism, which involves multi-system dysfunction like lung, skin, and brain. Mainly involvement of the lung and brain. So fat embolism is different from fat embolism syndrome. We have already explained you before. So fat embolism and FES are not synonymous. FES is a group of symptoms and signs because of fat embolism. Fat embolism may be or may not be associated with fat embolism syndrome. It is classified by SIDE.IT classification, which was put in 1962. It is divided depending upon the clinical presentation: subclinical variety, non-fulminant variety, and fulminant variety. So this is one way of classification. The etiology most commonly is a blunt trauma, producing in 90% of the people Long bone fractures like femur, tibia, humerus, pelvis, pelvic bones, etc. And there are some we call as a non-traumatic causes. We'll be discussing further. So in a traumatic causes, long bone fractures, pelvic fractures, fracture of other marrow containing bones, orthopedic procedures like nailing, etc. Soft tissue injury, particularly chest compression with or without rib fractures, extensive burns, liposuction, and bone marrow transplants. In this condition, there is a high chance of getting fat embolism, and which can end up with fat embolism syndrome. While in a non-traumatic condition, one of the most common is diabetes mellitus, pancreatitis, osteomyelitis, sickle cell, acute sickle crisis, steroid therapy, bone tumor lysis, etc. And once in a while, alcoholic fatty liver can also end up with lipid infusion, particularly very commonly done in a parenteral nutrition, TPN, and once in a while, cyclosporine A solvent. These are the common conditions which can be non-traumatic conditions. We already mentioned in traumatic condition, fractures of long bones and pelvic, burns, particularly nailing, arthroplasty in orthopedic side, and subcutaneous adipose tissue injury. Liposuction, bone marrow transplant comes another group. Closed fractures, incidence of FES is more than open fractures. It is more common in younger people than old people. Single bone fracture has got 1 to 5% and multiple fractures has got more chance, as well as shaft of femur will produce more chance of FES. Some of the risk factors, it is more common in male, age between 10 to 40 years, post-traumatic hypovolemic state, reduced cardiopulmonary reserves, injury related, we already mentioned multiple fracture, bilateral femur fractures, femur shaft fractures, lower extremity fractures, traumatic fractures, pulmonary injury, and surgically related, particularly nailing, in femoral fractures, joint replacements, even bone marrow transplants, etc. Already incidence we have mentioned before, it is high with femur fractures, almost going to 5 to 10% if it is bilateral and multiple, and mortality rate can be as high as 15%. There is no specific laboratory test. Mostly it is associated with long bone or pelvic fractures, more common with closed fracture as compared to open fractures, and it occurs within 24 to 72 hours from initial insults. Pathology, it is described, there are two common mechanisms. Exact mechanism is not known, but it is said that mechanical or biochemical theory. Mechanical means fat globules which disrupts from the bone marrow or adipose tissue are forced to torn venules in area of trauma. And biochemical is hormonal changes caused by the trauma and or a sepsis which releases free fatty acids and chylomicrons, which will results into systemic effect which we call as a FES. So there are two mechanisms, mechanical and physiochemical. In mechanical, there is a physical obstruction of pulmonary or systemic vasculature embolization. It will temporarily increase the pressure which will force the marrow into injured venules, venous sinusoids. Cor pulmonale, inadequate compensatory pulmonary vasodilatation. Microvascular lodging, local ischemia, inflammation, release of inflammatory mediators, platelet aggregations, vasoactive amines, veno-arterial shunting, hypoxia, leading to alveolar hypoperfusion, and that will lead to pulmonary disorders or pulmonary involvement. Fat globules can be from 2 microns to 200 micron size, and blood vessels will be occluded by almost less than 75 microns fat globules. While in biochemical, circulating free fatty acids directly toxic to the pneumocytes and capillary endothelium in the lung, which will decrease the surfactant, will lead to interstitial hemorrhage, edema, and chemical pneumonitis. Local hydrolysis of triglycerides and fat emboli by pneumocytes lipase, which further increases the free fatty acids, and coexisting shock, hypovolemia, or sepsis reduces liver blood flow, and it will increase the toxic effect of free fatty acids. So fracture liberates fat globules, fat uptake by venous system, fat causes obstruction, and that obstruction can lead to skin signs in the form of petechia, very commonly seen in the skin and eye, that is conjunctiva. So on a conjunctival surface you will see petechial hemorrhages, and over the skin also you will see a rash with petechia. Also it will block the lungs, and in lung it will produce hypoxia. If it is person is having patent foramen ovale like ASD, it can bypass through that, leading to involvement of the brain, and person can have hypoxic damage like confusions, etc. So a shock can produce multiple symptoms like release of catecholamine, phospholipase, and it can involve DIC. Shock is secondary because of trauma, hypovolemia, or sepsis. There is also release of C-reactive protein, which will exaggerate agglutination and release of free fatty acid and chylomicrons, which will activate platelets and microvascular plugging, which will produce end organ damage, as well as bone marrow disruption can also result into fat embolism, release of free fatty acids, and end organ damage. As far as clinical feature is concerned, classical triad, that is hypoxia, neurological symptoms and signs, and petechial rash. Usually within first 12 to 48 hours the person is asymptomatic, and symptom will start within 48 to 72 hours, which will be because of involvement of the lung, brain, and because of skin involvement. 0.9% of the patient with the long bone fractures will get this particular symptoms and signs. 52% of the time single long bone fractures, and in multiple long bone fractures 48% of the person. Among the symptom, hypoxia comes topmost on the list, then tachycardia, which is almost in 93%, elevated temperature in almost 70%, unexplained anemia in 67%, altered mental status right from confusion to drowsy 59%, and petechial hemorrhage in 33%. So most common is hypoxia and CNS involvement. It is always diagnosed by high index of suspicion. Initially there is an asymptomatic, and then symptoms will start after 48 to 72 hours. A fulminant variety can present as an acute cor pulmonale, respiratory failure, and person can die within few hours of injury. Diagnosis is made clinically but not by laboratory parameter, and it will occur within 24 to 72 hours after initial injury. Classical triad: hypoxia, neurological abnormality, and petechial rest. In respiratory system, dyspnea, tachypnea, and hypoxia signs. As far as neurological sign is concerned, right from confusion to seizures. There may be focal neurological signs like hemiplegia, aphasia, apraxia, visual field defects, anisocoria, etc. And among the petechial rash, it is very commonly seen in conjunctiva, oral mucosa, and skin over neck and axilla. And it will appear within first 36 hours, and then it is self-limited, and it will disappear completely within 7 days. Entire treatment is mainly supportive care for as far as respiratory system is concerned and CNS is concerned. So early signs are dyspnea, tachypnea, hypoxia, and CNS signs in the form of confusion. In respiratory system, person will have a symptom signs of hypoxia, rales, friction rub may be heard. We call crackles and wheeze may be heard. ARDS may develop secondary due to fat embolization. Half of the patient with fat embolization syndromes requires mechanical ventilations. And on X-ray chest, you will see typical, this is called snowstorm pattern. And CT chest will show you ground glass opacification with interlobular septal thickening. This is characteristic. So tachypnea, dyspnea, and hypoxic signs with rales and friction rub and picture like ARDS, high temperature, hypoxia, person may develop even acute cor pulmonale, and chest X-ray will show you typical snowstorm pattern, and CT chest will show you ground glass opacification. As far as CNS is concerned, it is almost as common as in 80% of the patient with FES syndrome. There will be focal deficits or seizures, but this is not so common, not common, but can occur. It is usually transient and reversible. There is an altered level of consciousness right from mild confusion, delirium to coma. CT head, CT scan will show you generalized edema, and MRI will show you low density on T1 and high intensity T2 signals. There will be diffuse encephalopathy. Person can have confusion, stupor, coma, and person can have a local focal signs to generalized signs, and these are transient and reversible. MRI, we already mentioned, low density on T1 and high intensity on T2 signals. Rash, reddish brown, non-palpable petechial rash, mainly seen in the upper and anterior part of the body, involving chest, neck, upper arm, axilla, shoulder. Also may be seen in the oral mucosa and conjunctiva. Almost seen in 20 to 50% of the patient. It appears late but disappears within hours. It is from occlusion of dermal capillaries by fat globules and extravasation of RBC. Typical rash. You can see typical rash over the body. This is over the chest, right up to axilla, neck. So it will be seen over the neck, axilla, etc. It is because of extravasation of RBC, and it will resolve within 5 to 7 days. And it will be present in 20 to 50% of the patient with FES. There can be other findings like retinopathy. In fundoscopy, you can see exudates, cotton wool spots, and retinal hemorrhage. In urine, you can have a lipiduria. Fever may be there, right from 39 to 40 degree. You can have clinical evidence of DIC. You can have involvement of the coronary blood vessels, which will produce myocardial depression in the form of prominent S wave, T wave depression. This will be very common. We call S1Q3T3 pattern. You can have RBBB and you can have atrial arrhythmias. As far as the blood picture is concerned, thrombocytopenia, anemia, and hematocrit will be reduced. You can have hypocalcemia also. In subclinical fat embolism, you can have involvement of a cerebral and skin with retinal involvement. In subclinical variety, usually you come across laboratory abnormality in the form of tachycardia, tachypnea, and temperature will be elevated. Moderate hypoxia, decreased platelet count. It is usually after 3 days of post-trauma, very commonly with involvement of the long bones, and it is characterized by little decrease in the PaO2, hemoglobin is decreased, platelet is decreased, and by and large there is no clinical symptoms and signs as far as respiratory involvement is concerned. In non-fulminant subacute variety, there is respiratory failure symptoms and signs, fever, tachycardia, petechia, and cerebral signs. Petechial rash are more common, and this rash will appear within 12 to 96 hours. Retinal lesion may be seen in the form of a cotton wool spots, hemorrhage, and person will have a PO2 reduced with blood picture of anemia, thrombocytopenia, and X-ray chest will show you lung opacities. So we already discussed this particular part. There is no definitive test, but when you correlate with the traumatic injury and other causes are ruled out, you can suspect FAS. In fulminant variety, it is a severe variant where there is a severe hypotension, cerebral signs, severe hypoxia, and frank pulmonary edema with acidosis. So respiratory failure, acute cor pulmonale, and embolic neurological symptoms and signs are very, very common. And this will happen very frequently with multiple fractures, quite common, and the mortality rate is high. We already mentioned other involvement like retinopathy, lipiduria, fever, DIC, myocardial depressions because of acute cor pulmonale, thrombocytopenia, anemia, decreased hematocrit, and hypocalcemia. There is one criteria called as a Gertz criteria for diagnosis, which includes major criteria and minor criteria. In major criteria, axillary and subconjunctival petechias, PaO2 less than 60, and CNS depression, which are included in major criteria. While in minor criteria, tachycardia, pulse more than 110, temperature elevated, retinal embolism, and lipiduria. But there is little modification further done. If you get 1 major and 4 minor plus fat microglobinemia, it is straightforward in favor. So they use in major criteria petechial rash, respiratory symptoms, clinical grounds as well as with radiography changes, and cerebral signs. These are 3 groups: skin involvement or retinal involvement, respiratory symptoms and signs, and cerebral signs. While in minor criteria, tachycardia, pyrexia, retinal fat or petechia on fundoscopy, oliguria or lipiduria, anemia, thrombocytopenia, and high ESR. So 1 major out of these 3 or 4 minor out of this, what we call as it is nearly, we can say 1, 2, 3, 4, 5, 6 and 7. Out of 7, 4 minor criteria. With fat microglobulinemia means in blood you demonstrate laboratory parameters that there is microglobulinemia, fat substances. So there will be reduced platelet, increased ESR, fat globules in sputum, etc. So then you can label that as classical FES syndrome. That is a modification by Gertz and Wilson criteria. These are major, minor and laboratory picture. You can go through your leisure time. Then came Scunford Fat Embolism Syndrome Index. This is that index where they include petechial rash, alveolar infiltrate, hypoxia, confusion, fever, heart rate, tachycardia, that is, and respiratory rate more than 30, and score is given. And depending upon that score, you can put them into that different category. So if score is more than 5, you can confirm the diagnosis of fat embolism syndrome. So if you look here, petechial rash score is maximum. Then came Lindeque's criteria. These are those criteria. Depending upon that, you can confirm the diagnosis. Investigation mainly to find out the severity of involvement of the respiratory system, that is ABG. Urine and sputum examination for fat globules. Hematological test like anemia, thrombocytopenia and low hematocrit. Usually biochemical tests are not very helpful, but to find out the effect on different organs, damage to different organs, certain biochemical tests may be helpful. So hypoxia, thrombocytopenia, anemia, hypocalcemia may be finding as far as ABG and blood parameter is concerned. Prothrombin time and ESR is elevated. ABG will help you to find out hypoxia and acid-base imbalance, particularly acidosis. Fat globule can be demonstrable in urine, sputum or in blood. Serum lipase level may be elevated and blood lipid levels will be also elevated. X-ray chest is pathognomic, that is called snowstorm appearance. ECG will show you S1Q3 T3 pattern with RBBB or with arrhythmia like atrial fibrillation, and typical diagnostic triad, that is thrombocytopenia, PaO2 less than 60 and rashes, conjunctival and skin rashes, even oral rash. So chest X-ray will show you snowstorm appearance and CT will show you ground glass opacification. CT scan will show you white matter petechial hemorrhages. Helical CT scan can be also helpful to find out lung injury. This is typical that scan which will show you lung injury pattern. This is fracture bone. Closed fracture will have a high chance as compared to the open fractures. In CNS CT is non-specific. MRI low density on T1 and high intensity on T2 signals. So MRI brain will be helpful. In differential diagnosis, you will have to differentiate from ARDS and pulmonary embolism mainly. And there is another condition called as a thrombocytopenic purpura, thrombotic thrombocytopenic purpura. Treatment is mainly supportive. Positive pressure, ventilation, CPAP, mechanical ventilation, antibiotics, nutritional supports, steroids, and heparin. Oxygen to maintain oxygenation of all the vital organs. may require a mechanical ventilation, hydration, glucocorticoids. So maintain oxygen, maintain hemodynamic stability. You might require a blood products, hydration, prophylaxis for deep vein thrombosis, nutritional supports. After care and damage control, early immobilization is preventive. And then as soon as everything settles down, so keep airway patent, fracture should be immobilized, restore blood volume, fluid loss, electrolyte balance, and avoid careless handling of the injured part. Respiratory support in the form of oxygen and mechanical ventilation is absolutely necessary. Treatment of shock, including IV fluids, even vasopressor, blood transfusion, albumin, etc. Steroid is helpful. Heparin to prevent blood clotting. Low molecular weight dextran can be useful, and even hypertonic glucose to decrease the free fatty acid production, and it will improve arterial oxygenation. Intravenous alcohol reduces lipase activity, limiting free fatty acid production. And treatment of fractures by fixation, so that you can early immobilize the part and prevent fat embolism. Complications, mainly ARDS and acute cor pulmonale, which has got a very high mortality, and that can end up with acute respiratory failure. In CNS, embolism and damage to the brain. By and large, it is reversible, but may produce a irreversible damage also, and it can end up in death. Death is very commonly because of acute respiratory failure. ARDS is very common. Residual damage may persist. Residual neurological deficits may range from non-existing to memory loss, cognitive dysfunctions, and long-term focal deficits. Diagnosis of FES is always by high index of suspicion. Most effective management is prevention with rigid fixation of a fracture within 24 hours, and management is always supportive. So I end my lecture here. I thank you all for taking out time. I know that your time is valuable, and I appreciate you for spending some of that time with me. I know that this lecture is odd, but once in a while you can see this fat embolism and fat embolism syndrome. If you clinically suspect, you will be able to pick up and you will be able to reduce the mortality. No doubt it is very commonly seen in an orthopedic side and on a surgical side, but even in a medical person can also face this problem.